the founder, director, and
This meeting is being recorded.
President of Semicolon Society, an Arizona nonprofit organization providing free community mental health education, as well as suicide prevention and post-vention education and supports. Dr. McCall is passionate about mental health education and suicide prevention and has collaborated with multiple school districts and local agencies to build suicide risk assessment procedures and provide free community supports and education. Her proudest role, though, is that of being a mom of her 2 children. So thank you, Paula, for being here today, and I will let you take it from here.
Thank you so much. Can I just ask, I can't share my screen yet because it's already being shared. So, okay, great. Let me go ahead and get my PowerPoint up. Hang on. Let me get this going. Okay. That should work. If there's any problems, let someone know and they'll tell me. So thank you. Thank you for the introduction. I'm really excited to be here. I'm really excited to see all the people. There's some familiar names on there for me and people from as far as New York, it looks like even. So I'm very happy to be here. I want to talk today about we're going to talk today about COVID and suicide risk, and basically looking at this overall context within the last couple of years with COVID and otherwise of what we've learned in regard to suicide risk assessment and prevention, resiliency, critical aspects related to suicide risk. I do focus largely on youth. So the majority of my presentation is targeting youth suicide risk assessments, prevention, resiliency factors, and so on. However, that being said, a lot of this information carries across age groups, and there's certain areas that are a little bit more particular to youth that I'll emphasize, but a lot of this information and approaches does carry across the ages. So I do want to take a moment to note that we're going to be talking about some sensitive topics. So sorry, I had a technical glitch there. I'm good. Okay. We're going to be talking about some sensitive topics, and please just take care of yourself. These are difficult, sensitive topics. I know we come from a lot of different variety of backgrounds. Many of us have experience working with individuals or perhaps ourselves or family members who have been suicidal or at high risk. And we might be thinking about some of those pieces as I'm going through this presentation. If you need to step away and take a break, please do so. Take care of yourself. I want to emphasize too that some of the information we'll be sharing might be different than what you've known before or how you've approached situations before. And please, let's not shame ourselves. Let's recognize that we're all learning, and this is an ongoing learning process. So, but if you need any support, please reach out to someone. And of course, the 988 Suicide and Crisis Prevention Hotline is available 24/7 for whatever's needed. So in our objectives today, we are going to be talking about the impact of COVID on mental health and suicide risk. And we're going to be talking about how that's affected suicide risk assessments. We're going to talk about suicide risk assessments, the key components of risk assessments. And we're going to also be talking about some of our most critical resiliency factors, as well as risk factors that are present both since the pandemic and in general, and talking about some of our youth, especially who have been found to be most vulnerable in response to the pandemic, as well as overall over recent years, and how we can move about supporting them. So we're going to be targeting all those pieces, looking at COVID, looking at vulnerability in our youth, looking at suicide risk assessment and those components and how it relates to the pandemic, touching upon virtual suicide risk assessments as well, and then talking about how we can support. We do have an hour and a half for a lot of content, so I will try to move along. I do try to naturally pause at certain points to see if there's any questions. So at that point, someone will let me know if there's any Q&As. If you have questions for me, please make sure that you put them in the Q&A in the chat. They might get missed. Also, we did discuss getting the PowerPoint out to people who are attending the presentation following the presentation. So you will be receiving this PowerPoint. And I do have a direct email at the end. You can contact me if for any reason you do not do that. So Real brief on youth suicide. We all know that there has been an ongoing increase since about 2007. So we've been looking at the steady increase in suicide rates, and it's not just in our youth. We're seeing suicide rates across age groups, across backgrounds, across cultural backgrounds, and so on. Suicide is the second leading cause of death for our youngsters ages 10 to 14, and third leading cause of death for our older adolescents. So one of the things unique to youth suicide is that it does follow a consistent trend generally, which shows that there's suicidal ideation and attempts increasing around January, March, April, October. And we think about the school year, that those are peak points where students are very active in school. There's a lot of demands and stressors and so on. That by no means that school is the cause of suicidal ideation. We just know that during those times a year, there's a lot of factors going on, not just school and academic demands, social pieces, extracurriculars. There's just a lot of pieces going on. And we do actually see a general decrease among youth in June, July, December, when they get really that built-in break from some of those stressors. There's a lot more complexity to suicide, of course, but we do see that general pattern. I think that's an important thing to note, because when we talk about adult suicide rates, we often see a tendency towards an increase in December around the holidays. And so it's actually a little bit of a different presentation among our youth overall. So I want to talk about what happened with suicide rates in the pandemic. And it's really interesting to look at the information as it's coming through, that in those initial months of the pandemic, that March to May period of 2020, there was actually a temporary decline in suicidal ideation and attempt in community mental health. That actually showed generally across the age groups, but we especially see that with the youth, that there's this temporary decline. That's normally a period where suicide rates would be higher for our adolescents. So there was a shift there. And we'll talk a little bit about some of those pieces that contributed to that shift. At this point, the rates have basically gone back to the way that they were before. The rates and the trends have pretty much gone back, but we had that short window where that was different. Generally, people managed the first month of lockdown, and people started struggling more mental health wise around the third month. Now, it was also during those first couple of months that we saw simultaneously a temporary decrease in cyberbullying, where people started being kinder to each other. They also were not seeing each other in person as much, which sometimes fuels the cyberbullying piece of things. We also saw an increase to crisis hotlines, where people were calling and seeking out mental health support. So it wasn't that people weren't struggling. It was that there was this temporary shift where there was kind of a societal normalization. How are our kids? Are we okay? Are you okay? And we started talking more about mental health within the context of the pandemic. And it became more normalized to reach out for help. And people, again, the cyberbullying kind of decreased. We saw a kind of an increased kindness towards each other for that initial first couple of months. After the initial decline, then we started seeing suicidal ideation and attempts tended to follow patterns of lockdown. And now at this point, we're kind of just seeing, again, kind of a return to the trajectory where we were at before. But we saw that shift. Now, when we think about COVID in the context of crisis, it actually absolutely fits within the definition of a crisis. And we look at some variables of what a crisis is. The impact of a crisis situation is different on every single person and every group of person, because it depends on some of the variables and how much that affects us. So when we look at things like what type of crisis is it, we struggle with, it's harder for us to adapt and adjust to crises that are, for example, intentional by another human, because we have that complexity of understanding why would someone do something like that. Predictability, the level of consequences, how duration, how long something lasts, and how intense it is. We think about that in the context of COVID, and we see that there's been there's definitely some variability in how it's affected people differently and how it continues to impact people over the extended period of time. So what we know about a crisis is that it's any situation that results in feelings of hopelessness, helplessness, powerlessness, don't know what to do, we don't know how to manage. Well, that absolutely defines COVID, the pandemic, especially in those initial months when we're all kind of shell-shocked and not sure what we were going to do and what was going to happen next. And we were still under the impression that this was just going to be a couple weeks and then things would be back to normal. So, but what we see then is the variables of crisis, especially related to predictability and duration, really started having an impact on us over time and our mental well-being. So as you have something that extends duration-wise and becomes more unpredictable, especially over time, that affects our overall adjustment, our perception, our hopefulness for the future. All of these things are directly related to suicide risk. And when there's more consequences and more intensity of that impact, you see higher rates of suicidal ideation and attempt. And we do see that specific in the pandemic, where there's certain areas of the world that were really intensely impacted. And the consequences were so significant across the board that we actually saw community rates of suicidal ideation increase in those areas. It's also important to note, especially as we're talking about youth, that perception is reality. And sometimes we forget that piece a little bit, and we think something about, perhaps they're being overly dramatic or things like that, or they're not looking at the grand scheme of things and those kinds of pieces. And that can be true, but the perception is their reality. And we need to recognize that and ongoing, that whatever we perceive, for all of us, whatever we perceive our world to be, our safety to be, that's my truth. Whether or not someone can dispute it, that's what my truth is. And that's why within the context of the pandemic, what we'll see is that parental response especially has been a critical factor in how our youth have adjusted to the circumstances coming from the pandemic, and also in any crisis situation. So just talking a little bit more about mental health and COVID, some of the pieces that have impacted is that there's positives and there's negatives, and everything kind of ebbs and flows together anyway. But what we saw is that there was this period of intensity in those first couple of months where we had to shut down and be with our families, and we had to protect each other. And there was a sense of intense connection among many family units. We know this is not the case in all family units, of course. And we know that domestic violence situations increased and substance use increased, especially in households where those already were present. So that is not a global overall, but we do see some general change where there was an intense connection within family and a sense of protecting each other. One of the key pieces in suicide risk is feeling like a burden, or feeling like you're not, that you just cause problems. If our focus is shifted to, well, I have to do this, I have to stay home because I have to protect my parents, it's not as much of a burdensomeness feeling. So we saw that intensity of connection. Overall, there was an increase in how parents and teens communicated, with a lot more positivity, that teens felt more connected to their parents. Parents' positive reinforcement increased of their teens. We were just around each other more. And so we saw like this family response that was really powerful and positive in many situations, although not all. However, we also saw this as a short-term shift. And so because of that, we ignored things like routine. We had, we went to bed whenever, and our adolescents woke up and then they did the online things, and we kind of lost a grasp of some of those things that were important. Well, and that might not matter so much if it had been a 2-week duration, but as we got to more and more months, we realized that our youth, especially, had lost the sense of routine that's just really important in mental health and stability, and that other pieces like coping strategies and so on were no longer accessible and no longer felt that they could be. So we had hopefulness decline over time, and we also had information change back and forth, and people changed their interpretations back and forth. So it just created this really long-term sense of instability, frustration, hopelessness. So that all makes sense within the context of the pandemic. The thing that's one of the pieces that's interesting is, what does this mean for our youth? Who were the ones who were most affected by all of this? And what has been most notable in regard to suicide risk and ideation and attempt is that those behaviors increased notably in groups who had pre-existing conditions. So anxiety, depression, sleep challenges, inattention, hyperactivity, irritability. They already had something pre-existing occurring, but they hadn't experienced suicidal thoughts with that before. So we have these adolescents, youth, who were already at an elevated risk for that trajectory towards suicide. And when you added on that intensity of the crisis, the ongoing crisis of the pandemic, we saw them shift to a different level. So We also saw notable other things where it was like everyone just kind of got to another level of intensity. Our autistic youth, for example, experienced higher suicidal ideation, higher anxiety, and increased social problems. And then we saw our youth with eating disorders, the high level of reactivation of symptoms, being home 24/7, and also the impact of that break of care that we had, where even when providers went virtually, the shift to virtual therapeutic environment was still jarring for many clients and patients. So there was still the continuity, the support systems therapeutically were really shifted and changed, and that impacted our youth who were already getting mental health supports. So from that piece, we see that an increased vulnerability of suicide among our youth who have pre-existing conditions in new highly stressful situations such as a pandemic. But we see an increased vulnerability among other youth groups as well, not just in the pandemic, but in general. I do want to emphasize here, as many of us know, suicide is a complicated act. It does not discriminate. There's no profile of suicide. So what I want to do is highlight a couple areas that we know are higher vulnerability, but it certainly doesn't negate the risk of suicide among any individual of any age, any background, and so on. Some of the other things that we found among our youth who are most vulnerable to suicide, when we talk about exposure to a suicide by a peer, so we have the community impact when another youth dies by suicide. The ones who know about this suicide and have had recent negative life events have an increased vulnerability to suicide, whether they knew that individual or not. And that's oftentimes an area that's missed in supporting some of our students is following a suicide, is that we do support these close friends, but we sometimes miss how the impact of just being exposed to a suicide can be to someone who's already struggling and going through a hard time. We also see that among those friends, we tend to focus on those most immediate, closest friend group who do need supports. But what we see is that it's the extended friends too who really struggle and have an increased vulnerability to suicide following a death by a suicide. So not just necessarily the closest friend groups, but maybe the people who they chat with every now and then, who they aren't maybe regularly with, but who they've known for a while, who they consider a friend. So being aware of that ripple effect in response to a suicide and how that truly does affect our community. Also, I want to point out that we have seen more and more that our Black youth have a higher ratio from ideation to attempt. They are more likely to attempt than other minority groups, actually any other groups. So that's something we need to be aware of. There's increasing awareness that the warning signs of suicide and how suicidal ideation may manifest may be misinterpreted in our Black youth. And that's something that needs to be further explored and discussed, but something to be highly aware of as well. Some other groups that have been shown to have a higher vulnerability to suicide is the invisible risk group. Well, this was about 8 years ago. At this point, we know that this group is a risk. But 8 years ago, we weren't so sure. We were just figuring out what the impact was of using internet and gaming and being sedentary and having not much sleep. But now it's pretty clear, we pretty much know that those individuals are at a higher risk. It's not just gaming or using the internet and social media. While they can have impacts, it's also combined with that piece of being sedentary, not having other things that we're engaging in, not having a balance, and not having enough sleep. We'll talk about sleep in a few minutes as well. And then we also have what we call a silent risk group, which is often females who engage in very low self-disclosure, but have underlying interpersonal challenges that could be very subtle. It could be a lot of relational types of bullying rather than outward bullying. But they also perceive that their parents are not supportive, and they perceive that no one can help them. And that is it's a very scary group because they're not seeking support and they're not sharing with adults, any trusted adults, about what they're experiencing, because they're holding it in because their perception, which is their reality, is that no one can help them. So they often suffer in silence, so to say. So that's another group that we're concerned about. And I absolutely emphasize how important it is for us to be aware of our vulnerability in our LGBT+ community. and taking just a second to recognize how significant that is. Over half of our sexual minority young adults report suicidal ideation. 45% of our LGBT plus youth have seriously considered suicide in the past year. And more than half of those were transgender and non-binary. So even within the LGBT community, we see an elevated risk among our transgender and non-binary youth. Gay and lesbian youth also consider suicide at more than twice the rate of their straight peers and attempt at 3 times the rate of their peers. So still high elevation. In addition, this group of youth, our LGBT plus youth, are at increased risk for depression, anxiety, substance use, cyberbullying, family relation problems. And all of those things are risk factors towards many things, including suicide. Now, one of the pieces that I think is a powerful piece to share and for us all to be aware of, because a lot of times it's hard for us, many of us are providers, supporters, might be in school professionals, things like that, that we are looking for ways, answers. How do we get people to help our youth? And one of the highest things is using their names and pronouns. Notice I don't say, and I intentionally removed the word identified names and pronouns from my presentation that I used to refer to, because it's not identified names and pronouns. This is their names and pronouns. And highly rejected LGBT plus youth, one of the aspects of highly rejected is not using names and pronouns. And when this happens across home, school, and peer groups, that makes you highly rejected. When you're highly rejected across those 3 groups, that youth are 8.5 times more likely to attempt suicide from that rejection across the 3 areas. Now, one of the things, there's many things that need to be done and many ways to support this group of students. But one of the things that we can do, and we can tell our colleagues, our staff, our parents, whoever we're working with, community members, is that just using the names and pronouns in home, school, and peer environments halves suicide risk. So just doing that in itself is a significant buffer against suicide risk. So I want to emphasize that we need to be very aware of our LGBT plus community and how high their risk really is in that sense of rejection that they experience. So I want to pause on that note, kind of doing that overview with that and vulnerability before I talk about specific suicide prevention, just to see, are there any questions that have popped up?
I have a question for you, Paula. This is Rachel Rubenstein. So you talked about identifying and the increased rate of suicide, and I wonder, you might be getting to this later, but how parents can talk to their kids about suicide risk and those kinds of things. So that is my personal question.
And that is a great question. We will touch upon that a little bit. I do feel that we have to do a lot better in our community education and our education of our parents about how to have conversations rather than just saying, watch for XYZ. We need to talk to them about that. So I will be touching on that, and please feel free to ask any clarifying as we move along.
Excellent. Great. Thank you.
So key aspects of when we talk about suicide prevention, it's not just 1 or 2 things. There are multiple aspects of suicide prevention. And the best that we can do as a community is knowing that these is trying to make sure that we are implementing these across the community in multiple aspects. This takes a lot of stakeholders. This takes government stakeholders who are passionate about this, takes school boards to be on board, school districts to be working. This takes community organizations, providers. This takes a whole lot to get to all of this, but there are multiple aspects of suicide prevention. One of the big ones is building resiliency and being able to be focused on how do we build resiliency in ourselves and in our youth, making sure that there's resources, making sure that there's ways to identify and support people who are at risk of suicide. And that really, it's not just a matter of telling people what phone number to call, but how do we work among our own community to actively recognize when there is a concern and not waiting more passively for someone else to tell us that there's a concern. Community awareness education is a piece of that. School-based services and supports, reduced access to means. One of the pieces that we do know is that over half of completed suicides are completed using a firearm that was obtained in the home, majority of which were obtained in the home. And when we talk about reduced access to means, that's another piece to how do we truly make our home safe, even with the presence of firearms, and how do we do that? So that's a whole nother piece. And then recognition also that whenever there is a suicide in our community, postvention support is so important for our youth and for the community. And within that, that postvention support in itself becomes prevention, because we know that there's a higher risk of suicide among community members, especially in the first couple of months right after a suicide in the community. And some more than others, but we recognize that basically everyone's at a higher risk, at least for some period of time. And if we're able to provide support on a postvention level, we're actually providing prevention support for suicide. But what I want to talk about is suicide risk assessment. And that's going to look in a lot of different ways. And it kind of depends on where your situation is. If you're an individual provider, or if you're in a school. I've done a lot of trainings with school districts to build in team-based approaches, utilizing a crisis team model, because really, ideally, suicide risk should not be determined by one person. It should be determined by multiple people through the use of multiple informants whenever possible. That's something that can be addressed within the school system. It's harder for those of us who are individual providers. I know I myself, I'm my own practice, and it's me. So recognizing that there's different elements and how that looks. So I want to try to speak to it in kind of a general sense, so that that can be used however it needs to be used within your own circumstances. So, but suicide risk, we need to understand that this is a process of estimating likelihood of suicidal behavior based on multiple components. It's a process of estimating. No one is guaranteeing, and no one is talking about long-term. And I'll talk about that in a second. The purpose of a suicide risk assessment is to understand where that person is at and what circumstances they're in that are more likely to contribute or to buffer additional risk, and how to determine the next best steps for them in that moment. Outcome of suicide risk assessment should always be some sort of support planning. That's the whole outcome. The whole purpose of a suicide risk assessment is to figure out what to do next and how to support this person. And that's why an interview is so important to have, because we can really tap into multiple pieces. The purpose of a suicide risk assessment is not prediction. We cannot predict suicidal behavior. We cannot guarantee that someone will not engage in a suicide attempt. And that's because suicidal ideation can vary dramatically over just a few hours each day. And I would say many of us have probably had that experience even within an hour of a day. It can escalate and de-escalate very quickly. Suicide is complex. There's multiple pieces that go into suicidal behavior. So we cannot predict that what's going to happen and what's not going to happen. A suicide risk assessment gives us the opportunity to understand where the person's at, what's their story. Let me hear you, let me validate where you're at, and let's identify points of prevention and intervention that we can move forward from here. The support plan itself becomes suicide prevention, and that comes from the interview process. There is very little evidence for the validity, reliability, or utility of our distinctions of low, moderate, and high risk. There's very little evidence out there because it really doesn't mean much. Now, people like to have some boxes to check, and people like to try to conceptualize, like, what is all this information and what do I do with that? So there's been some level of reconceptualization, and this has been seen in threat assessments as well as suicide risk assessments. So risk assessments related to harm to others and harm to self, that there's been this reconceptualization. Now, there is still a 3-level piece, but the idea here is we're not saying low, medium, high, and somehow that's going to inform what to do. What this is it tries to kind of conceptualize a little bit more of, okay, so is it more of a transient, vague piece, concern? What does that mean? and looking at pieces like, what about the stressors? What about coping methods? What about baseline? We talk about baseline is a really important piece, is knowing what our clients, our youth, what their normal is in suicidal ideation, because there are many people who have some level of suicidal ideation at certain points in their lives and in their days. And it's important also for us to understand that, and to help the people that we work with understand their own, so that then they can notice when there's been a change in that baseline. And then we have that substantive. So this is a substantive level of concern, some presence of a plan. There's current coping may not be as effective as before or as accessible as before, which we certainly have seen with the pandemic. Notable stressors that may have popped up or are coming up. And then we have this very serious substantive, where there's a direct threat, a plan, which we know a plan increases the risk of actual suicide completion. Access, imminent danger, imminent warning signs, some of which we will touch upon as well. But with the idea of this reconceptualization is we're not just checking off low, medium, or high risk, we're conceptualizing the information that we're getting from the person that we're talking to about where they're at right now. This is a momentary conceptualization. In this moment right now, this is where we're at. And this is going to help guide me, because no matter what, no matter if it's transient, substantive, or very serious substantive, something's going to happen. There's going to be some sort of support plan and intervention for this individual. What that is going to look differently for each situation. But, and what that is going to be fueled by the information I've gotten through this interview process. But this helps give me a little bit of clarification about where I'm at with that intervention and support. But it doesn't stop at that point. Now let's talk about suicide risk assessment in itself. There are 4 critical evidence-based elements related to suicide risk assessment. If we are not assessing all 4, we are not doing a comprehensive suicide risk assessment. Risk factors, warning signs, current ideation, those are usually present to some extent in a suicide risk assessment. What we forget sometimes to include is the protective factors. What's going well? What is there access to? What are the things that are valued and valuable right now? And we need to make sure that we're incorporating that as well. That is often the source of information about what to do next, what to tap into, what kind of supports are needed. They may already be present. They just may need to be tapped into in a different way. So we want to talk about each of these. And overall, a couple pieces related to the pandemic and how that's affected them, and then moving forward with how that all looks in a suicide risk assessment process. Risk factors, I don't even know at this point. I think the last I saw was that there's 118 known risk factors out there. What we know is that there are many, many factors in our lives. And the more risk factors we have, the more risk we have. And this isn't just risk factors for suicide. This is risk for substance use, anxiety, depression, risk factors for multiple pieces. So we know in general that there's a lot of risk factors out there, and that pretty much every youth that we talk to has had some amount of risk factor, and every one of us as adults has experienced some sort of risk factor. All that does is elevate my risk towards a trajectory, towards a certain path. It doesn't mean I will go that way. There's a lot of mediating variables on whether or not my trajectory takes me towards suicide or not. The thing that's important for us to focus on in a risk assessment is, while it's important to be aware of those fundamental factors that that person comes forward with us, we know that our goal is to develop some sort of support and intervention for this person. We're not going to be able to change the fundamental factors. They're important to recognize as a risk factor. We also want to make sure that we are tapping into the proximal, more immediate factors where there is some opportunity for intervention and control. So our fundamental factors, the trauma that someone has experienced as a child, the background of an individual, their geography, whether or not they're LGBT, plus those are pieces that are good to know. We can't change those. But what we also want to make sure we're assessing for in our conversations are things like relationship crisis, grades, suspensions, expulsions, major losses, loss of freedom, social disharmony. And again, I emphasize that perception is reality on these. If we have a teenager, for example, in front of us who is saying, I have no contact with my friends. My parents took my phone. I can't connect with anyone. They're going to go on without me. I've lost all my friends now because I won't have my phone for a week, or whatever it may be. We need to recognize that that is a genuine perception of their reality. And we need to hear that as it is. Suicide risk assessment is not meant to change someone's perception. It's to find out what that perception is so that we can work from where they're at. So what we see is that those more immediate risk factors that we actually have some impact on, we may or may not be able to control whether or not they happen, but we have the ability to help support in things like coping, buffering, getting other supports in place, reducing the intensity of the impact, and so on. But what we see is that the mostly proximal risk factors have been found to co-occur with death by suicide in our youth groups. School problems, arguments, conflicts, into significant other challenges, family relationship problems, crises that have happened or that we know are going to happen. We know some things that are coming up in our lives, whether it's a move or a change or a parent moving out, or whatever that may be. So, but we see that there is a high percentage of co-occurring proximal risk factors, significant proximal risk factors, significant events happening to our youth around the time that they died by suicide. So we really need to tap into some of those pieces. Again, perception is reality. And this is where it's important that we're not minimizing any of that significance. One of the things we often do too is minimize, I say as general, as adults, is that we tend to minimize some of those experiences of our youth, because we know from our own experiences that, when they're our age, it's not going to matter. But their context, they are not our age. They are 15, they're 16, and that it absolutely does matter at that time to them. So again, our focus is on finding out what their perception is so we can work with them from where they're at and not change what that is. We also, by looking at these proximal risk factors, we're able to get information about what kind of support's needed. Is there problem-solving skills that need to happen? Is there mediation? Do we need to develop coping skills? Do we need to address bullying that's happening? Whatever that is, finding out about these proximal things that are happening in their lives is important information for building a support plan. The support plan intervention is always the outcome of suicide risk assessment. Another piece to consider, very much to consider, in looking at risk factors is family relationships. And it's such a critical component, especially when we look at our most vulnerable students. What are those family relationships? We know family relationships in general is a huge, significant protective or risk factor, depending on how it is for our youth. But what family relationships even in our most vulnerable youth populations. So when we look at historically minoritized students, or in youth, we can see oftentimes that there is some sort of disconnect between our youth and their parents, who the parents may have immigrated themselves to the United States, for example, and that there can be a huge gap in what that looks like. There can be a conflict in their values and experiences. Their parents may really struggle with accepting their youth's normal teen activities, normal American teen activities that they may find actually shameful or inappropriate based on their own cultural background. Also, there's going to be challenges just in understanding what mental health is. I came across, I had one person, youth, who I evaluated, who, when did further exploration, found out that there was absences in their native language that even referred to things like anxiety and depression, that there really weren't even words for it. So how could their parents understand and validate and support and help them cope when they didn't even see it as existent? So, and there's also a lot of times we can see an element of shame on mental health issues as well. So it's really important to recognize, to tap into some of those pieces in those family relationships. With our LGBT plus students, we see parents who are struggling supporting differences in how they appear, in changing their name, not being able to do it or refusing to do it. It is absolutely a grieving process for our parents of transgender and non-binary youth who change their identity in their eyes and change their name, even though that's the person they've always been to them. That is not how their parents have interpreted them. And there is a really big conflict in the youth moving forward and coming out and trying to embrace themselves as their genuine self, while the parent is struggling to understand what that means. So we see that as a huge critical component to be aware of. And we also see disapproval for the community. And it may not even be overt. It could be very subtle. It could be things like, do you have to hang out with them? They're so loud. They're like, the clothes they wear is just so, you can have like these more subtle disapproval pieces, but that's going to limit our youth from then connecting with the peer groups that they want to connect with, going to the support groups that they want to go to, because of that disapproval. So that's another important piece to be looking at when we're looking at risk factors, is those family relationships. With COVID, some of our higher risk factors has been a lot about parental response and how parents have reacted and their stress level. And we'll also see how parents have modeled coping helped as a protective factor. But parents who are very highly reactive and highly stressed, and then you couple that with social isolation, financial hardships, we had a lot of youth very much perceiving academic challenges and saying that, no, what's this going to mean for me to get into college? No, this isn't going to, all these pieces, I'm going to fail. I'm not going to learn what I need to know. Perception is reality. That was what they perceived it to be. Risk factors that also mattered makes sense: being in a red zone, having a first line close relative who with higher concern about them. Excessive media exposure is always a higher risk for challenges in any sort of crisis event. Anytime we're immersing ourselves into media exposure, we are putting ourselves at higher risk. We have to find a way to balance that. And then pre-existing conditions. So those are some of the risk factors that have mattered with COVID. That was a lot within the category of risk factors. So let me check and see if there's any questions.
Hi, Paula. I'm going to circle back to a question. When you were first talking about the use of identification and pronouns, using personal names like Jane or Jim, or pronouns like him, her, can you talk a little bit about can you just talk a little bit more about what the difference is between identification and pronouns and just that general topic?
Well, I think it's about language, I think, is what that's referring to. Language matters, and how we frame something is how it matters. So if I refer to someone as, well, yeah, I'm going to use their identified names and pronouns, that's subtly suggesting that that's what they picked, but that may or may not be true. And if instead I say, okay, I'm going to use their name and pronouns. If someone comes up to me and yesterday they were Jimmy and today they say, I'm Jane now, that's their name. That's their pronoun. And so the idea there, I think, is more of an emphasis on language. Language really does matter. When we talk about suicide too, there's a big, you've heard me say died by suicide, that we no longer use committed suicide because people commit crimes and it attaches to the shame and stigma of suicide. So I think that's just another example of how language matters and how we refer to people's experiences.
That's so interesting. And then someone put in the comments preferred pronouns as well, that language, how that implies that, there's that subtle judgment there.
It's their preference, but it doesn't mean it's right.
Right.
Yeah. So it's their name and pronouns. That's their name. That's their pronouns.
Thank you.
Yeah. So now we shift into talking about the second element of a suicide risk assessment, and that's a warning signs. So we talked about the risk factors, the higher areas of risk. But now we talk about actual warning signs. These are a piece that's really important for us to educate parents and community members about, and our youth themselves, and how to recognize in each other. This is a big heart component of suicide prevention, is knowing and understanding different warning signs. Now, not everyone shows the warning signs, and there are situations where it's so subtle or perhaps even not apparent in any way. So of course, this is not global, and it's not everyone. But these are a lot of warning signs that we do see. And one of them is talking about making plans for suicide. And I think as professionals, many of us are, as providers, recognize that, not so much necessarily with our youth among community and parents, because sometimes it's referred to as being dramatic, as, you know, and they're just looking for attention. And I always try to refer to, so what if someone's looking for attention? If someone's talking about suicide and they're looking for attention, isn't that a good thing? Isn't that good that they're saying, hey, I'm thinking about this. I need your support. I need you to listen to me. So I try to bring down that whole stigma about what that even means. It's a way to dismiss our involvement in something that's uncomfortable, but that's not what's most important in these situations. Feelings of hopelessness about the future, feeling like a burden to loved ones, and especially when you attach those together. So feeling like a burden is going to come out in different ways. You know, my parents would be better off without me. I just cause problems. I always upset my friends, things like that. Hopelessness could be, about future plans, college, things like, what's going to happen? Do I feel like I'm ever going to feel better? No. But when you attach those together, especially if I'm feeling like a burden and I don't have any hope in the future getting any better, then where is there to go from that? So those are important pieces to be aware of as well. Severe and overwhelming emotional pain or distress, emotionality that physically hurts, and it does. The dysregulation, difficulty in regulating and balancing out in utilizing coping strategies. Some of the things that we might hear is that I used to do this and it doesn't help anymore. That's a significant piece to be aware of as well. And then marked changes in behavior. So withdrawal, agitation, irritability, emotionality, changes in sleep, anger, hostility. Those are just changes, like something changed. And I encourage those of us that work with parents to empower them with knowing that and to following their parent gut, their parent intuition. When something's changed, when something's different, to pay attention to that and not to dismiss it. And I mentioned sleep. So there's been some interesting research coming out with sleep that there can be a predictive piece of sleep problems that are predictive of next day suicidal thoughts. Not always, but we can see that there is enough to say that these can be predictors. When we look at what the sleep factors are, they kind of make sense. Longer time falling asleep, right? So we're not getting enough sleep. Sleep is a huge piece related to mental health. Having nightmares. And we often see nightmares correlating with onsets of depressive episodes or anxiety periods of time, that nightmares can be associated with those mental health challenges. So it can be a reflection of what's already happening. And then ruminative thoughts before sleep, someone who's thinking over and over and over again and stressing and that high anxiety before they go to sleep. Well, that's how they're falling asleep. And so we're seeing like this tie to possible suicidal thoughts the next day. It's really important to know. I think it's interesting to note that there's been studies comparing like, well, if I wear a sleep monitor and it shows that I took a longer time falling asleep versus me saying I took a longer time falling asleep, my self-report is much more predictive of my mental health. And I think that comes to understanding that perception is reality. So even if it only took me 20 minutes to fall asleep, but I'm saying it took me hours, my perception is I'm struggling to fall asleep, and that affects my mental well-being as much as the lack of sleep itself. So these are another pieces to be aware of, because again, as we get this information, it's giving us ideas and information about what our next support steps and intervention steps are. Sleep hygiene, relaxation strategies before bed, and so on. It's important to think about warning signs within the context of COVID. It's to identify, has this always been this way? When did this shift? When has a change been? Was there a change related to the pandemic? Considering aspects of burdensomeness and hopelessness in the context of the pandemic, for example, the child whose family shut down everything because of a medical condition that everyone was concerned about. And they did that out of love and care for the child. But there's this child seeing their family shut down and not connecting socially and missing things that they used to like to do. And that can make them feel like a burden or perhaps hopeless about the future. We also see this in youth whose parents have been very sick. For example, parents with cancer, and or other, and autoimmune issues, whatever they may be, and our youth shutting down for them, but then, so they don't necessarily feel that burdensomeness, but in a sense they do, because then as things start reopening, do I go and risk my parents' life to hang out with my friends? And then feeling guilt and challenge and confusion in those navigating those kinds of decisions is a very high piece of stress for our youth.
Dr. McCall, we have a question that's perfect
Yeah.
timing.
Yeah.
This person, who I believe is a clinician, said, regarding family relationships, one main theme that they have seen with COVID and family dynamics is a lot of shaming and anger on family members who are being blamed for bringing home the virus and infecting other high-risk family members, especially when death occurs.
Yes.
And this person is wondering, do you see any impact of that contributing to suicidal ideation risk, and how to stop that from evolving into a crisis?
Yeah, that's a really good question. I think that's a really important observation, and that how that blame happens and how that's transmitted. And we also see on an opposite end, we see family fragmentation that's happened because people have disagreed on how to navigate the pandemic. So we've also seen shame and things like that on, why are you still wearing a mask? You know what? We don't need to be around you because you're overreacting, or vice versa, or you're underreacting. And especially in those cases where unfortunately there's been actual infection and loss and death. And so, yeah, I think that those are just important contexts, that anytime there's a division in our family and that there's any sort of anger and that kind of dynamic towards family members, that always is a risk factor for increased suicidality, anxiety, depression, multiple mental health challenges. And I think the piece there is, perhaps if that's what we're seeing as one of the factors, then one of our supports, one of our interventions may be some level of family therapy, perhaps, or some sort of support in navigating those family dynamics, setting boundaries, things like that. It's informative information to have that we can then use in planning.
Thank you.
Yeah. When we talk about warning signs, it's also important to note upon some imminent warning signs. So just making sure that we're in line with that. When there's an agitation over being found out, like, I can't believe this, I can't, getting angry, getting upset, getting hostile over being found out about suicidal thoughts. That's important to recognize, because a lot of times in our youth, there's not necessarily a relief, there's an emotional reaction. There's different types of reactions, but that increased agitation suggests that there's already been steps taken forward to move forward along those lines, and now that's been interrupted. So we need to be really aware of that agitation when it comes up. Increased statements about suicide, increased emotional response, that's significant feeling of being a burden. If there's a presence of a plan, it's 50% more likely that someone is going to attempt. The risk just jumped up. So we want to know if there is a plan in place, what that plan would be, and getting more information about what those kinds of thought processes. Once we shift from the general, more abstract idea of dying by suicide to how to die by suicide, we see a mental shift into becoming more of a concrete piece moving forward. A strong desire for death is another imminent warning sign. I just want to die. A lot of times people who die by suicide or attempt suicide, have suicidal thoughts, don't want to die. They just don't know. They don't know what else to do. The emotionality is too intense. Everything that's happening is too intense. It's coping strategies aren't working. I feel like a burden. I can't find any hope. I don't know what else to do. When we hear that strong desire for death in itself, that's another imminent warning sign. And insomnia, especially coupled with some of the other pieces, we see periods of insomnia preceding suicide attempts. Not quite sure where the causal look, if that's correlational, if that's causal, if that's reflective of a mental state the person is already in, but that's a piece to be aware of, that in that presence of insomnia in recent days can be an imminent warning sign as well. So those are also pieces that we want to make sure we're tapping into in a suicide risk assessment. Stepping from that, we need to talk about what the current thoughts are. How often are they happening? How intense are they? Scales of 1 to 10 can be helpful in that. Help me understand what this was like. How intense have they been before? Where are you at today comparison? Again, that comparison to baseline is really helpful. What's your day-to-day intensity of suicidal thoughts? Well, they come in my head, but it's like a 2. Okay, so what is it today? Today it's a 7. Being able to recognize what that is, how long they've been happening recently and overall. And then again, looking at the plan, accessibility is a key piece in thinking about what our immediate steps are going to be. Just the presence of a plan, whether accessible or not, though, like I said, is indication of mental movement to a concrete steps. So we need to be aware that a plan in itself is a high level of concern, especially when there's accessibility. And when someone talks about backup methods, I'm going to do this, and if that doesn't work, I'm going to do this, then that's also a high level of concern that's gone to an extra level of planning. I've already mentioned this before. It's important within the context of COVID to talk about if there's been changes. There's been changes to the baseline during the lockdowns, current activity, how suicidal thinking looked before and recently. It's not the only piece to consider, but as we're having conversations about suicide risk, that's one piece that we want to make sure we're incorporating into that discussion. A question that has been found to have some really good predictive value to it is this one. How confident are you that you will be able to keep yourself from attempting suicide? It's a great question. It speaks to that personal, that my internal awareness. It's non-judgmental. It's just asking where I'm at and where my confidence is, and really just where my mental and emotional set is at that point. Again, this is all momentary. This is all right in the moment of where I'm at right now. But that can be a really helpful question that's been shown to have some predictive value in suicide risk assessment.
Dr. McCall,
Yes.
There's another question that's perfect
Yes.
timing. What are some examples of a client saying they have a plan, and how do you see passive versus active suicidal ideation?
So, well, some examples, a lot of times is part of the suicide risk assessment. I'll show some examples of questions we can ask in a suicide risk assessment. We'll be asking, do you have a plan? Have you had a plan? And you're going to hear different variations of that. You might hear no. You might hear, yeah, this is my plan. This is what I'm going to do. It might be, a lot of times it can be more, it's in that intermediary piece. Well, I've been thinking about this. Or I've been thinking about this that's in my house, and more of a, like, it's starting to formulate. So it is important, no matter what, if there's suicidal thoughts of a more passive nature, like I think about killing myself and then I move myself away from that direction, that's still an important piece to be targeting. What our interventions and supports are going to look like at that point is going to vary based on what those suicidal thoughts and plans are.
Thank you.
Mm-hmm.
Thank you.
And then that fourth element that I talked about was protective factors. But keep in mind, honestly, if we're assessing risk factors, we're assessing protective factors. If we're trying to get an idea of how the family environment is going and we're hearing, oh my gosh, my parents are so supportive, we're actually getting protective factor information too. If we're hearing, yeah, school's really hard for me and I get bad grades, the only class I like at all is my theater class, then we're also got a protective factor in addition to risk factors. So it's important we're not necessarily assessing a whole different area. We're looking at something that we are incorporating, but we're attending more to some of those positives, some of those things that are supportive, some of those protective resiliency types of factors, things that are happening at school, in life, socially, family, just in general, like coping style, optimism, things like that, that I think I'll get through it. Not quite sure how, but I think I'll get through it. Those are protective factors that we need to make sure that we are targeting as we're moving forward into what our supports and intervention might be. There's a lot of traditional resiliency factors that we found over the years: coping skills, social support, inclusive environments, having a connection with at least one adult who the youth truly believes to care about them and is there for them beyond their parent. So who's that one adult that they have, if not more? Feelings of hopelessness, feeling a sense of belonging. Giving to others has been shown as a resiliency factors. If you think about it, if we're giving to others, if we're helping others, whether in a more formal volunteer situation or something just more general, like I try to say something nice to someone every day to brighten their mood. For giving to others, that directly counters a feeling of burdensomeness. I can't be a burden if I'm making someone feel better. So that's another piece. And then I've already mentioned the importance of using name and pronouns. In COVID, we've seen some impact on resiliency factors. There were some potential positives in that family communication and connection in many families increased, at least for a short period of time. Our youth were able to adjust in ways that many as adults struggled a little bit more with, because they already had their social media network. They already had their gaming network. So they were able, while there was still a loss, absolutely, in that in-person connection, they were able to transition very easily because they already had that exist for them. And then there was some level of reduction of stressors for many of our youth. For example, many school districts said, you know what, this is your grade and you can improve it, but you can't go down for the rest of the school year. So go to class, do online, do your assignments, you can improve your grade, but no one's going down. And that was a huge relief to many of our youth to say, oh, thank goodness, because they had to learn how to navigate this whole online system. Then we had negatives too, with those in-person peer interactions, not being able to connect with extracurriculars and other situations, just being out and about with friends and feeling like you belong, and then the changes in routine, therapeutic care, and so on. So we definitely see both of those sides. The factors that were protective, that have been protective in the COVID pandemic: consistency and stability. How important is routine, right? And having that consistency and having stability, and knowing that for our youth who they had financial hardship and didn't know where they were going to get their next meal from. That's not just COVID, that's any time. That is a huge impact. But having consistency and stability is a huge piece. Parental modeling of adaptive coping. That's another piece of parent education that we can omit easily, but it's really important to talk to our parents about how much they model coping. They're telling their child that they need to not overreact so much. How are they responding to stressors in their life? Are they modeling some of those coping strategies and what they would want? If they're telling their child, I want you to tell me when you're upset, but they hide it and they go into their room and cry quietly, although the child knows exactly what's happening, is that a model of emotional communication? No. So that's not going to support our children in doing what we want them to do. Having open and honest communication, access to social connections, humor was a big factor, a protective factor in COVID, and varied activity, that not sense of acting trapped, that even in quarantine, even in some isolation, we were still maybe going out and going for walks. We're still finding ways to not feel trapped. So it's part of our interviewing process for a suicide risk assessment. It's important to consider some of these things about how have things changed within the context of the pandemic, relationships, coping skills, supports, and also talking about what's been gained that wasn't there before. Many of us can identify something that's changed for us, and perhaps in a positive way, not to negate the negatives, but to also say, you know what, I've really shifted my priorities. I started being more attentive as a parent, or I started really breaking down what's most important for me to accomplish in the day, or I tapped into some creativity that I've always wanted to, but I didn't have that before. So it's also important to understand that within the context as well. So I want to show you some examples. And again, everyone should be getting a copy of this PowerPoint, but some ideas. These are examples of questions that I've utilized in some suicide risk assessments that I've helped develop with some school districts, but can also be utilized on an individual kind of provider level as well. When we're looking at how do we ask the questions, how do we ask about ideation? Here's some examples. How do we ask about a plan? This is not meant to be a step-by-step. Question A, question B, question C. This is meant to be kind of be a guide of here's some things that I want to make sure I tap into, and I can kind of reflect on this list and make sure that I actually reached all the pieces that I wanted to get. So this would be an examples of ideation and plan questions. And then we also have questions about risk factors and warning signs, about how would you describe your life right now in 3 words? Those 3-word questions can be really powerful. How have things changed? What are your challenges? How do your friends and family see you? What do you have? What kind of family relationships do you have? Do your friends and family call you by your name and pronouns? Those types of things that we've talked about as being such important factors. And many of those things can be directly targeted through intervention and supports in some way when we have that information about what that looks like. So again, not necessarily a step-by-step list of questions, but an idea of questions that we can use to tap into the pieces that we really need for an effective suicide risk assessment. And then tapping into the protective factors. This also isn't an order thing. A lot of times, especially with youth, it's a lot easier to start out and say, tell me what's going good for you. What are those 3 things that are going right in your life right now? How do you feel? What about activities? What coping skills do you use? Are they still helpful? And then you start shifting into it. That being said, I also want to emphasize it is important for our youth, and I feel for anyone, to know why we're sitting down and having an interview with that person, and to say, I heard you make some comments about suicide, and I want to talk about that more. I want to get more information about where you're at so we can help build a support and intervention plan that's going to actually make sense for you and actually help you. I think it's important that we are direct and straightforward about the things that we are talking, and especially with our youth, who oftentimes feel like as adults, we're, talking around things, to make sure that they know that we are being direct, and that, and why we're doing the things that we're doing, and that we're there as a support. A few notes about a suicide risk assessment interview. It is not counseling. It's not meant to change the person's perspective. I mentioned that before. We're getting information. We're finding out where they're at. It's an assessment. I'm finding out where you're at and what your experience is right now and the circumstances around that. It's not a time for me to share my own story. And also in general, especially with youth, it's important that we don't promise confidentiality when that's not what we're able to do. We know that we need to disclose suicide risk to adults, to parents and guardians. So that needs to be an important piece as well. The youth can guide us in how that looks. They can have opportunities for control, and in that process, which parent should we call first? Or your mom's in the waiting room. Do you want me when we bring her in, do you want me to talk to her? Do you want to talk first? And giving some opportunities for control over that situation, so it doesn't feel as much like a crisis, as much as it's an opportunity for support and planning. Just a few communication approaches that are important, that can be helpful with anyone. It's okay to circle back around. Are you having thoughts of suicide? No, I don't know why you're asking me that. That's fine. Tell me what's going good with your life. Tell me some things about school. Tell me about your family. You can ask more and more questions, and you can circle back around to the suicidal thoughts. One strategy that can be really effective is providing gentle assumption of suicidal thoughts. That you shared with me all these struggles that are going on at home, at school, and things like that. And I know when someone's having struggles in all those areas, it's not unusual for someone to sometimes have thoughts of suicide. Is that something that you can relate to? And that can give a very non-judgmental approach to saying, it's okay, we can talk about it, and reduce some of that stigma. Symptom amplification is another effective communication approach, where, for example, if we have someone who's saying, I don't know how often I think about suicide, then we amplify it and say, so like 100 times a day? And they would say, no, like 5 or 6 probably, to adjust that. That's also a strategy used a lot in substance use assessment, as well, amplifying so that you get the actual accurate answer. Make sure you're looking at open body language, not just typing responses on a computer, those types of strategies that I know we all know are important, but sometimes in the moment we get caught up in taking notes or something like that. So something to keep that in mind, as we're having those kinds of conversations. This is I always show a variation of this when I do parent education for parents, about what not to say and what to say, and always with the caveat that you've probably said something in both columns, and that's okay. We're human, and sometimes we might even hear something like that come out of our mouths, and it's okay. Youth can be forgiving. Anyone can be forgiving when we acknowledge our own mistakes. So if I hear myself say, oh my gosh, but life cannot be that bad, I can say, you know what? God, that is not what I meant to say. I really want to be here for you and hear what you have to say. So please, I'm sorry I even said that. I want to hear more about what you're experiencing. And it's okay. We can, if we acknowledge our mistakes. But we want to make sure we're not saying anything that's minimizing or invalidating or contributing to feelings of being a burden. What we do want to communicate is validation, support, and that we are here in the moment with them, and that we're going to work together to move forward. Virtually, I'm just going to kind of touch upon real quick. With virtually, some of us are still probably doing virtual therapy, and really a suicide risk assessment, as we all know, can pop up in the middle of a therapy session where something's said, and now it's like, I need to shift mode now and need to find out more, get more information about what's happening and understand this person's perspective and where they're at right now. Really, the model remains the same for a suicide risk assessment. The content remains the same. It's just that we need to look at making sure that we're building rapport virtually, recognize that we have less context about what's happening, that we don't get as many nonverbal cues, and that there could be things like disconnection and ensuring safety. So I think it's really important for those of us that do some sort of teletherapy or version of teletherapy, that we have a proactive stance, the information on how to reach someone, how to reach the parent or guardian, especially for a youth, if there was a disconnect or a concern for safety. And that's something that should be collected ahead of time, and that should be clearly communicated to the parent that, yes, your child meets with me every Tuesday at 3 o'clock, and I need you to have your phone on and be able to answer a call or text from me between 3 and 4 if anything were to ever come through. And that is your responsibility as a parent, just as if you were bringing them into my office and you were waiting in the lobby and I knew that you were there. So it takes some proactive steps to consider. So just making sure that we are aware of that context being different, and that we're still considering those pieces. I saw a Q&A pop up that time. Is there a question that would be a good one right now at this point?
Yes. Somebody asked, how do you make a distinguishment between someone being suicidal on a regular basis or a COVID related crisis?
So I think that's a really good question. And I guess that would be coming from your questions. What is happening right now? What's happening with family? What's happening with your circumstances? What are your coping strategies? What are the areas of challenge where, so you're going to get that information from that conversation. And then really, if it's suicidal on an ongoing basis versus in response to context, in response to a crisis, our point right now is to get a picture window where they are right now and how we can support them moving forward. So I may know, like, for example, someone may express to me that I feel like this all the time, and I am just getting more and more, suicidal as time goes on. Our intervention and support for that person might be a much more intensive piece at that point to help them stabilize and get to where they need to be. Then it might be in more of a situation that's response to, I'm feeling this way because I just don't know how to navigate this. And then that would be the support then, is figuring out how to help navigate it. So again, the suicide risk assessment, it's not so much about which, and I know this wasn't the question, but like which box to check, or, it's about gathering that information so then we can say what next. And so I'm going to kind of jump to that with support planning. So the whole purpose of a suicide risk assessment is to build some sort of support. And no matter what, there should always be some sort of support, intervention, whatever it is, that is identified through the process of the suicide risk assessment. The suicide risk assessment is not about what level of estimated risk. It's about, where is this client at right now? What do they need? They might need immediate stabilization in a hospitalized setting. That's possible. They might need more guidance in problem solving and identifying those challenges. They might need more coping skill strategies. There could be a whole lot of need, but we're getting that information through this process of the suicide risk assessment. All of that information now becomes intervention development. And there is such a difference when you sit down and you have that conversation and get that information, and then you're stepping into, I gave some examples before, like, I hate school, but I love theater. Wow, we have a piece right there. How do we build that as a support for this individual? How do we build from that? What are the parts of the school the rest of the day that's not working well, and how do we address that? And then how do we build the support that the student feels in that one classroom once a day? So all this information guides that intervention development into where we're going next. Anytime that there's something identified as an intervention, we want to make sure we're figuring out, okay, what does that mean? And how do we follow up with that? Some examples, some types of supports. Talked about parent education. We need to make sure our parents know how to support their children, and not just here's a hotline. Now, on the hotline note, though, I don't want to minimize what a hotline can do. One of the things that our parents don't recognize many times is that they can call the hotline themselves, and that they don't have to wait for an active suicide risk to use the hotline, that they can just say, my kid said this thing that was kind of concerning and I don't know what to do with it. So we need to empower our parents to say, these are resources for you too. And you can use these resources and you can tap into them, and that's okay. That's why they're there. And they wouldn't be there if other people didn't use them too, where they're needed and you can use them. But we need to also make sure that we're helping our parents understand how to respond to their children, with that slide of what to say, what not to say, how to communicate. I always emphasize validation and support. Communicate validation and support. Validation does not mean I completely agree or understand with where you're at. I'm just hearing you, and I hear that's where you're at, and I want to be here with you there, and I want to be here next to you, and I'm here for support. I'm here for next steps, whatever that next step might be. And sometimes if we have a crisis situation at home, for example, where our child is, crying and doesn't know what, we don't know what to do, then our next step might be, okay, right now, do you want something to drink? We want to also make sure that we're helping our parents understand resources in the community, like in addition to hotlines, what crisis teams are, how to call 911 and request a mental health response versus a criminal response, making sure that we're helping educate them on what those resources are, letting them know that there are people at the schools that can be contacted to talk about further supports and things like that as well. And then we also want to make sure that our parents recognize the need for our youth to have some sense of control. And the control does not mean that they're dictating the situation. We can have control within parameters. So we might say, no, you're going to stay home. But while we're home, how would you like that to look? What would you like us to do right now? Or I do think that we need to reach out to a therapist. But I know this website, Psychology Today, for example, that talks about all the different, so why don't you come with me, look online with me, and help it put together, give me your input on who you would be comfortable seeing. So we can help our parents understand they don't have to give up control to give some control to their kids. Other types of supports, safety plans, no longer safety contracts. A lot of us, I'm sure, are aware of that. The idea of promising another person not to do something is really can just add to a challenged relationship and fears of shame and things like that. So, but safety plans, empowering our clients, the youth, to say, okay, so what are your plans? 3, 2, 1 is just one motto, can be used in different ways. But for example, like 3 people I can talk to, 2 things I can do to help me relax, 1 hotline I can call, whatever it might be. But having a safety plan, these are the things that I'm going to do. These are my resources. These are my supports. Having coping plans, which is a variation of a coping plan, is more ongoing. How do I cope on a regular basis with things that might be challenging in my life? What are things that are distractors for me? And our youth have a lot of distractors, and distractors are okay, but they're not our only coping. So what can I use as a distraction? What can I use as an outlet? Who are the people I can go to talk about feelings? Who are the people I can go to who just help me feel better? And where are the places that I go that I just feel better? And coming up with those ideas. There's a number of apps that we can use for our youth that provide guidance. And actually, some research shows the value of having apps that support what therapy is teaching us. So for teaching mindfulness to our client and then help them download an app related to mindfulness, it's more likely that they're going to utilize it. It makes sense that they're going to utilize that kind of strategy in the future. Identifying areas to belong so that we don't feel isolated and alone. Helping schools, if we might be in the schools, or coming up with some suggestions for things that might be helpful in a school setting. One of those is called check-in, check-out, which has been used for other purposes in the past, but can be used also for mental health check-in, check-outs, where a student every day at the beginning and end of the day, they check in with an adult, and ideally the same adult, just see how they're doing. It can also be used for things like assignment management, things like that. Adult Connections, a 2x10 intervention, is one that's done in some school districts where I make sure I identify students, and this can be done in a proactive way too, where we identify the students that aren't connected to an adult. And every adult has a couple of students who or just one, where I'm going to make sure to have a 2-minute interaction for 10 days in a row with that student. And just by doing that, it naturally develops oftentimes an ongoing rapport and relationship. And then feelings of giving to others. Encouraging volunteerism. Volunteering as a family, that's another thing I encourage among families. What's the teen interested in? Is there something they can do? What makes sense to them as a family or with a parent? But I always do the precaution of, if you're volunteering with your child, that is not a secret way to bring up things like grades and things like that. That is volunteering with your child, which means that is what you're present doing together. Mentoring programs and things like that. But again, what each individual needs is going to be obtained through that process of interview and getting all that information about what it is that they need for ongoing supports. And so I see a couple questions pop up, so I want to make sure.
Yeah, we have some great questions. So a question from a counseling student asked if you could speak a bit more about how to encourage youth to share suicidal ideas and plans after reiterating confidentiality will not hold if there's a risk. And the idea of imagine them being found out and what that's.
Yeah, so I think there's definitely a proactive element to that for one piece. So if I'm seeing someone as a therapist on a regular basis, part of my first session is explaining confidentiality and limits of confidentiality. And one of the things I always emphasize is, there are certain pieces that, and this isn't usually a surprise, they know. But one of the things I emphasize is, so if any of these, if there's concern about risk of harm to yourself or others, those things come up, I will always tell you before I tell your parents. I will let you know in that session, hey, this is one of those things we're going to have to disclose. So let's talk about how to do it. And I'm going to include you in that process so that it's not done behind your back and you know exactly what's happening. And I will be here to support whatever reaction we get. And I think also, and in that moment, if it's more of an, like right away kind of situation, I think it's just the same thing. A lot of our teens, they just want to be talked to and heard and not, told the BS. They want to know what's happening so that they have some opportunity for control. So again, it might be like, okay, this is something I'm going to have to share with your parents. I'm here. Let's talk about how that's going to look and what we're going to do.
So interesting. So Dr. McCall, we are running out of time. I wish we had more time to hear you present. It's been so helpful. Do you have maybe 30 seconds of a final remark you want to make before we pass it back to Debbie? It was so good.
I think it's just, we're always all still learning. And if we just keep that piece in mind, that we're learning and that we need to have direct, open conversations about suicide, and we need to make sure that we're continuing to build ways to validate and support ourselves, each other, and our youth, then I think we're going in the right direction. And I'm happy to stay on for a little bit longer too, if anyone wants to. I don't know how that works with the webinar, but if there's any other questions, I can stay on for a little bit too.
Thank you so much. I'm going to pass it back to Debbie now.
Oh, here, I'm actually going to skip through. I do have some resources and references, but let me put, and again, I'll send this out. But there's also my email is the best way to contact me. So.
Perfect. Thank you so much. This was fascinating. So much great information. Sometimes I wish in these webinars that we didn't have like the time limit, because I feel like there's just so much more that you could have covered that we could have asked about. So thank you so much. I am going to put up, this is our QR code for reviews. If you feel like you have an extra couple seconds, we would love a review. I think Aurora is an awesome place. I love working there. And if you think we're an awesome place, check in there and give us a review. I will remind everybody that we will be getting CEU certificates out to you sometime in the next week. Please give us to next Friday. Look online for upcoming, we're going to have an upcoming parent webinar that is going to just be fantastic in January sometime. And then we will also have another CEU presentation in January. So thank you everyone who hopped on today and attended. Thank you so much, Dr. McCall. It was amazing. Absolutely loved it. I hope everyone has a very, very Merry Christmas and a Happy New Year, a Happy Hanukkah and all of the things. I hope that your holiday season is amazing and wonderful. And thank you so much for attending. If you guys didn't attend, we wouldn't be doing these. So I appreciate all of you. I'm glad you're all in my life. And I hope you all have a wonderful rest of your week. Bye.